A laparotomy is a surgical procedure involving small incisions through the abdominal wall to gain access into the abdominal cavity. It is also known as a celiotomy. This operation is performed to examine the abdominal organs and aid diagnosis of any problems, including abdominal pain. In many cases, the problem once identified can be fixed during the laparotomy. In other cases, a second operation is required. Staging laparotomy for Hodgkin's disease or lymphoma includes splenectomy, needle or open biopsies of both liver lobes, possibly also removal of abdominal nodes, abdominal node and / or bone marrow biopsies, ovarian repositioning. The physician makes an abdominal incision and the abdomen is explored. The spleen is mobilized, divided from its vascular supply and removed. Needle or wedge tissue samples are obtained from the left and right lobes of the liver for separately reportable analyses. Abdominal and retroperitoneal lymph nodes are identified and sampled. A bone marrow biopsy may be obtained. The ovaries may be plicated out of a planned radiation field. The incision is closed. Laparotomy, for staging or restaging of ovarian, tubal or primary peritoneal malignancy, second look, with or without omentectomy, peritoneal washing, biopsy of abdominal and pelvic peritoneum, diaphragmatic assessment with pelvic and limited para-aortic lymphadenectomy. This procedure is the second operation to check for a recurrence of the ovarian malignancy. Through a full abdominal incision extending from just above the pubic hairline to the rib cage, the physician may elect to remove the omentum, a membrane of lymph, blood vessels, and fat that forms a protective layer that extends from the stomach to the transverse colon. The physician may flush the lining of the abdominal cavity, peritoneum, and remove the liquid to check for cancerous cells. A tissue sample of the abdominal and pelvic peritoneum may be taken. The physician also may examine and take tissue samples of the diaphragm. The pelvic lymph nodes are removed and a portion of the lymph nodes that surrounds the lower aorta within the pelvis is removed. The abdominal incision is closed with layered sutures. Laparotomy, with aspiration and / or injection of hepatic parasitic, e.g., amoebic or echinococcal, cyst, S, or abscess, ES. The physician performs aspiration or injection of liver parasitic cysts or abscesses. The physician makes an abdominal incision. The liver is mobilized and the parasitic cysts or abscesses are identified. The remaining abdominal contents are packed off with sponges for protection. The cysts are aspirated with a needle and syringe or unroofed and aspirated and may be injected with a hypertonic solution. The abdominal incision is closed. Exploratory laparotomy, exploratory celiotomy with or without biopsy, S. To explore the intra-abdominal organs and structures, the physician makes a large incision extending from just above the pubic hairline to the rib cage. The abdominal cavity is opened for a systematic examination of all organs. The physician may take tissue samples of any or all intra-abdominal organs for diagnosis. The incision is closed with sutures. Reopening of recent laparotomy. The physician reopens the incision of a recent laparotomy before the incision has fully healed to control bleeding, remove packing, or drain a postoperative infection. Sphincterotomy, anal, division of sphincter. The physician divides the anal sphincter. The patient is placed in jackknife or lithotomy position. The physician performs digital and instrumental dilation of the anus with exposure of the patient's anal canal. A small incision is made between the muscle layers of the anus and internal muscle is divided without opening the lining of the anus. Transduodenal sphincterotomy or sphincteroplasty, with or without transduodenal extraction of calculus. The physician performs a transduodenal sphincterotomy or sphincteroplasty and may repair the duodenal sphincter or remove a stone, as needed. The physician exposes the second portion of the duodenum via a subcostal or upper midline incision through skin, fascia, and muscle. The duodenum is opened using a longitudinal incision. The ampulla of Fata is identified and an incision is made in the ampulla at the 2 o'clock position. The common bile duct mucosa may be proximate to the duodenal mucosa and the duodenum transversely closed with interrupted sutures. Stones may be removed. The abdominal incision is closed. Hepaticotomy or hepaticostomy with exploration, drainage, or removal of calculus. The physician makes an incision into the hepatic duct and surgically creates an artificial opening. The physician performs exploration, drainage, or removal of calculus from the hepatic duct. The hepatic duct is closed primarily or around a tube for continued drainage. If a drainage tube is placed, a separate incision is made in the abdominal wall through which the drainage tube is positioned. The abdominal incisions are closed. Hepaticotomy or hepaticostomy with exploration, drainage, or removal of calculus, with or without cholecystotomy, without transduodenal sphincterotomy or sphincteroplasty. With transduodenal sphincterotomy or sphincteroplasty, the physician explores the common bile duct, removing calculus, draining purulent matter, and or constructing a new duct. The physician exposes the common bile duct within the portal triad through a subcostal or upper midline incision. The common bile duct is incised, explored, and drained. The common bile duct is closed with interrupted sutures primarily or around a drainage tube, hepaticostomy. If placed, the drainage tube is brought out through the skin at a site separate from the incision. The abdominal incision is closed. Report 47425 if this procedure performed with transduodenal sphincterotomy or sphincteroplasty. Cholecystotomy or cholecystostomy, open with exploration, drainage, or removal of calculus. The physician exposes the gallbladder through a subcostal or upper midline incision. The gallbladder is incised, explored, and may be drained. Calculi may be removed. The gallbladder is closed with interrupted sutures primarily or around a drainage tube. If placed, the drainage tube is brought out through the skin at a site separate from the incision. The abdominal incision is closed.